Hello, everyone, and welcome to our 3 p.m. CME Palooza session. I'm going to bring up slides here. This is Outcomes, a study in 3 acts. The session sponsored by Practicing Clinicians Exchange. We thank them for their support. Our panelists today are Jason Alveri from MedIQ, Andrew Bowser from Icon CME, and Jamie Ryder from CME Outfitters. Before we get started, a big thank you to all of our sponsors, our gold sponsors, Genentech and Prova Education, silver sponsors, SIM, Forefront Collaborative, Global Academy for Medical Education, Integrity Continuing Education, and PCE. And our bronze sponsors, ACHL, Clinical Care Options, CMEology, Global Education Group, Helio Education Lab, Highmark CE, Impact Education, Infograph Ed, Connective, PCN, PVI, RMEI, and Thistle Editorial. For all of you who use a big font for your logo, I do thank you for that. Makes my life slightly easier. And 3 ways to ask questions, as always. You can use the CME Palooza text line to send in a question, 267-666-0CME. You can click on the little Google Slides link that you'll find on the live page. I am Derek, so you want to click the one beside my name, not Scott's. And you can tweet your question using the CME Palooza hashtag. I'll be monitoring all these different channels. And then I'll be probably holding most of the questions till towards the end, if we have any, and then we'll be going over them then. And the last slide is our speaker disclosure slide. Opinions, discussions, and/or conclusions expressed are our own and do not represent an endorsement by or position of our employer, its parent company, or affiliates. So with that, I am going to turn things over to Jason. I want to give a quick, just to let you know how this session sort of came to be. People love outcome sessions, and we actually hadn't had one for a little bit. And so I specifically asked Jason, one of our favorite CME Palooza presenters, to put something together. I just sort of gave him free reign to do whatever he wanted to. This is what they came up with. I think it's really great. So thank you, in particular, Jason, for taking the lead on this.
Thank you, Derek. Love the opportunity to participate. And of course, thank you to Andy and Jamie for helping along with this. I'm really excited about this afternoon. We're going to be obviously talking about outcomes. The discussion is going to unfold over 3 acts. So I'm going to kick us off with the setup. You're going to get to meet young Johnny and learn about his very dramatic call to action, couched predominantly in CME study design. Andrew Bowser, with both Dash and Daring Do, is going to take us through the confrontation, looking at CME measurement issues. And Jamie Ryder, our we'll call her our CME statistical Jedi, is going to save the day with the resolution talking about CME analysis issues. That's 3 acts, 3 topics, 3 presenters. Somebody once told me that the only thing you need to be great are 3 guitar chords and the truth, which, if you think about it, is going to be completely irrelevant to what we're talking about today. However, it's kind of cool, and it's a 3, so that's my little pearl for you. Let's move on to the setup and meet Johnny. Next slide. Young Johnny was a curious boy. He believed in the town motto, to demonstrate knowledge, competence, and performance gains associated with participation in continuing medical education. Sir. And he loved his town. He just wondered, is there another way? The town leader laughed off Johnny's inquisitiveness. It's normal for a young lad to question his elders. You'll grow out of it. Now how about writing me up a nice pre-post test for the upcoming IBD webinar? And don't forget those p-values. Everybody just loves them. Johnny felt trapped. And he fell into despair. Luckily, Johnny found a good therapist. And eventually, time, as it does, brought healing. He met a girl. He got a job and became a big shot outcomes evaluator. There was peace in Johnny's life. But peace is too often an illusion. One day, a strange man came to town. He said he represented the Quasi. He told Johnny about a great war, an eternal struggle against the powerful randomers who control the meaning of everything. a fight which the rebel quasi fear they may never win. But there's a prophecy. Some believe there is one man who could lead the quasi to victory over the oppressive randomers. The quasi have been searching through the ages, a search which now ends with Johnny. Is Johnny the chosen one? I had a hilarious little segue there, but that's okay. Time to move on to something serious. So why the war? The ultimate goal of research, and that's what we're trying to do in outcomes. I mean, that's what we are doing in outcomes. It's research. We're trying to identify causal relationships. We have our presumed cause over here on the left, which is CME. This is our independent variable. And we're trying to create a presumed effect. Typically, it's going to be physician learning change or some variant of that. That's our dependent variable on the right, called dependent because it depends on the independent. These pesky randomers, they believe that cause and effect can only be determined by randomized controlled trials. The quasi, however, believe that these types of trials just aren't practical for most investigations, and that causal references can be made from quasi-experimental research. Randomers, randomization. Quasi-experimental. You get it. We'll go to the next slide. So what's so great about RCTs? Well, let's talk about it for a second. Look at the target population over here on the left. These are the folks you want to make smarter, taller, thinner, less hairy, whatever it is. You come up with some sort of a salve or pill or tool in order to make this happen. This is your intervention. And then you want to see what happens to the folks who experience the intervention versus folks that don't. And the difference between those two is the effect. The problem is, other than the thing you want to affect, folks in your target population have a whole lot of other things going on. Research in CME, for example, relevant to us, has identified more than 30 distinguishing characteristics of a CME participant. These folks are messy, and all of that messiness is getting in the way of us isolating the effect. So what do the randomers do? They throw up their hands. It's too hard. Forget trying to stratify these folks. We're just going to randomly pluck somebody from the target population and drop them in our treatment, and randomly pluck someone else and drop them in our control. And we're going to keep doing this until our really cool sounding power calculation tells us to stop. And the idea at the end here is that these guys are still messy, but because we randomized them, the folks in the intervention and in the control group are going to be balanced for that messiness. And now we can isolate the effect. Pretty elegant, pretty simple, and pretty much the backbone of every top-tier journal that exists. So let's move on and see what happens in CME. CME, we have the same issues. We've got our target population of physicians, or clinicians we'll call them. We already talked about how there can be more than 30 distinguishing characteristics amongst them. We have our intervention, which in our case is CME. And now folks self-select. They decide, okay, I'm going to participate in your CME, and they become our de facto treatment group. And now we've got other folks who decide to participate in our control. Now, I'm assuming some folks have played with surveys of physicians, and some folks have also sent out surveys to controls. It's remarkably hard to get people to respond. You gotta believe the small sample of folks who decide to participate in your control group are probably not representative of your target population or your intervention group. So what you're left with is a self-selected group of participants in your CME versus a self-selected group of participants in your control. They're non-equivalent, they're confounded. Because of this confounding, you cannot isolate the effect. Now, confounding can either amplify the effect of your intervention or it can dampen it. It can go in either direction, but at the end of the day, you won't be able to tease out, because of this confounding issue, what was the true effect. Let's go ahead to the next slide. This is an issue of internal validity. Internal validity is how well a study avoids confounding. Confounding being more than one possible independent variable acting at the same time. So if we look at our chart again, we've got our cause over here on the left. This is our independent variable. We want this isolated. The more isolated this is, the clearer of a line we have to our presumed effect, our dependent variable. But what's bracketed there in the middle are some example confounders. Their age, these are participants, of course, the comparison groups, differences in age, years in practice, specialty, patient experience, readiness to change, pre-existing knowledge, competency behaviors, practice factors, not just where do you practice, but do you get along well with your boss, with your staff? Do they have crappy coffee in the office? Patient factors. You may know how many patients someone sees in diabetes if that's your interest, but that doesn't mean that patient load is balanced. They may have different comorbidities. They all have different socioeconomic statuses. All of this stuff is clouding the link between cause and effect. So let's jump to the next slide and talk a bit about cause and effect. 3 conditions for cause and effect. First up, temporal precedence. We need to show that the cause, in this case our CME, comes before the effect that we're hoping to measure. The second thing we need to show is covariation. There's a relationship between cause and effect. And we can do this in 2 general ways. Number 1, we can show that with no CME, there'd be no change. Another way, and/or we can do this, is to show more CME equals more change. It's pretty hard to do covariation without a control group. Last up, back to internal validity, is no plausible alternative explanations. This is where we talk about all those things that are standing in the way between our presumed cause and a presumed effect, and we explain them away, hopefully, or minimize their effect. Let's go to the next slide and look at an example a little bit more tuned to CME. So say you wanted to go through steps 1, 2, and 3 for an activity. Let's start with step 1, temporal precedence. For our example here, the cause is going to be a series of 5 online enduring activities. We'll say they're 30 minutes each. The effect is an increase in pre versus post activity competency test score. So say you give them a case vignette or a case-based test pre and a case-based test post. That's looking at the blue versus the orange bar on the figure on the left. We do a test of significance. We're happy that we have a nice little p-value there. This is our argument for temporal precedence. We know what they came in with. We exposed them to something. We know what they left with. And what they left with was more than they came in with, temporal precedence. Covariation. Now we need our control group. Now we're looking at the blue bar versus the gray bar in the graph. So we've got pre-activity folks on the blue before they're exposed to the education, and the gray bar are folks who never participated at all. What we want to see there is balance or equivalency. We don't want those groups to be different. And we see, based on this hypothetical, very convenient example, that they're not different. However, the folks that went on to participate then had a nice bump in their competency score. This is our argument for covariation, in so much as where they're not the CME, the gray bar, there wouldn't have been an effect. However, we measured an effect. And lastly, step 3 is eternal validity. This is where we're going to touch on all the other explanations that might account for the effect we're claiming. This is not a statistical argument. There's no test that's going to get you through this. This is solely a function of study design and execution. So let's look at some study designs common to CME in the next slide and talk about some of their strengths and weaknesses as far as establishing temporal precedence, covariation, and internal validity. Derek, we'll jump ahead. Okay, so number 1 group pre-test, post-test only. Very common, probably in everybody's enduring activity. This is a knowledge post-test score for credit. The main benefit, wicked easy to implement. Main concern, no temporal precedence. You're only testing people one time. You have no idea if they've gained or lost. You just have an individual score. There's no covariation. You've got nothing to compare what would have happened if there was no CME. Essentially, you know nothing. It is an administrative function, but it does nothing to tell us how effective our CME is or is not. So now you're thinking, okay, I got up my game. I'm going to add a pretest, because the last slide talked about pretests. So now we move on to 1 group pretest versus post-test design. Probably very familiar to a lot of folks. You give people a pretest before they come in, they're exposed, and then they take a post-test. As we looked at with the last slide, this is a way to establish temporal precedence. Another added benefit here, we talked before about how folks are kind of messy. The folks who come to your CME are still going to be messy with all the reasons why they came. Who knows? However, by doing a matched pre to post comparison, you're at least ensuring you're comparing like-to-like groups. So it's going to strengthen your temporal precedence claim a bit. What are the concerns? distinct from the general population. There's a selection bias issue here. Our participants are distinct, excuse me, from the general population. We don't know why they participated. We don't know how they compare to the general population. That's a concern. There's also no control group to address external influences. If this CME activity never existed, would they still have had a competency gain from something else? Could be. Who knows? We don't have a control group to say so. So now, all right, up in our game again, we're going to add a control group. We're looking at the third line here, post-test only with non-equivalent control. And this is exactly that, a post-test to participants in your CME and a post-test to a allegedly representative non-participant group. What's the benefit here? Now we can make an argument for covariation. We can say something about what would have happened if this CME didn't exist. What's the issue here? You no longer have temporal precedence. You've lost that with the elimination of the pretest. Secondly, you've got a huge selection bias issue, like that figure we looked at a few slides back. The folks who decide to participate in your CME versus the folks who decide to participate in your control group, you have no way of knowing whether they're balanced. You can ask 4 questions, multiple choice, about what's their specialty or degree or practice type. That's not going to balance all of the other variables that could be possibly affecting your presumed effect. So now we're really up on our game, and we're moving to the 4th study design. That's pretest post-test with a non-equivalent control group. Now you're doing the same thing you were before with the previous line, but both your participant group and your control group are getting a pretest. What's the benefit? Pretest is back. You've got your temporal precedence claim. Control group is there. You can make assertions about covariation. And because you have a pretest and a post-test, pretest in both the treatment and control groups, your covariation assertion can be strengthened if you show there's no difference between those two groups. So said another way, if these 2 groups exist, they've got a bunch of other confounders attached to them, you give them the test of interest, and you find that they both score equivalently, you can make an argument that maybe those external confounders don't matter so much because the thing you're measuring, they were equivalent on at the start. What's the main concern? At the end of the day, again, it's selection bias. It's still going to be impossible. You can make assertions, and the assertions get stronger, but it's still impossible to show that these groups are equivalent. Let's move to the next slide. If it's not clear, selection bias is Johnny's greatest threat. I don't know if he's the monkey or if he's the banana, but either way, it's a problem. Next slide. So, if you can't beat him, you join him. This is Johnny's secret weapon to push back against the randomers. And this is where Johnny's quest and the quest of all the CME people out there converge. The idea here is if you can figure out how to practically and consistently apply this type of model, you're going to have significantly more robust outcomes. We're doing the exact same thing here we were doing in the previous last model discussed. The difference is we've added random allotment. So whoever decides to knock on the door of your CME activity, we can't control for who they are out of the target audience. However, if we can route them to, let's go back for just one more second, I'm almost done. I know I'm pushing my time. If we can route them into the treatment group and route them into a control group randomly, now we can assure that at least those 2 comparison groups are balanced. I know there's a lot of interest in, hey, we got chart data, hey, we have pharmacy data, hey, we have administrative medical claims, and having that kind of data is awesome. However, if you have great data and a crappy study design, you end up with really expensive and really time-consuming bad data. This is the type of model that we need to be applying specifically if we're going to be using more expensive and more valuable data. Let's go to the next slide. This is a reference slide. I'm not going to talk about this. Selection bias, I really hammered home on that as a threat to internal validity. It's a big one for us in CME. There's a handful of others that are very common. There's 8 that are pretty common in general research. There's 5 I have listed here, pretty common in CME. These are things you should be able to speak to when you're doing your outcomes research. Always lead with a headline. We kicked butt. We did a great job. That's fantastic. Journal articles lead with that. New England Journal of Medicine articles lead with that. However, at the end, there's always that limitation section that says, well, yeah, I mean, we're awesome, but there are these 5 things. This is how we try to control for them. If you can't speak to these things, it dramatically limits the value of your data. Let's go one more. That's my spiel. We're going to move on to Andy for the confrontation. Once the plan is determined, your study design, it's time to pass on and make sure that the tools you use are proper. And Andy's going to talk about survey design and ways we can improve the measurement in that regard. So Andy, over to you. Thank you.
Okay, thanks, Jason. So we'll pick up with Johnny's story here, and the title of this leg of Johnny's journey is Useful, Valid, and True, or Why Distractors Matter. And I will be your director and producer for this segment of the journey. I think the situation now why Johnny's looking out the window and he's so forlorn is he's got this great brand new secret weapon that Jason provided him, this random assignment, pre-test, post-test, non-equivalent control group design with random assignment model. There must be an acronym for that, right, Jason? But now he realizes that he has to actually design the study. And really, when it comes down to it, we want to be able to tell the stakeholders that our education matters and that we've actually done something great here with the target learner population. But if we had a confidence question here, the question would be, how confident are you that your outcome study is valid? How confident are you that you're measuring what you say you're going to be measuring? And so we're going to be talking about a little slightly bit of a different type of validity than what Jason was talking about, but a similar kind of approach. And I think the best way to do that is to start with an example, the next slide, which is how many surrealists does it take to change a light bulb? And of course, we all know the answer to this question is a fish. But actually, as we did a little more research on this, I found on a UK website that some folks think it's a bicycle. But then as I really dug in and did some intensive research on Reddit, I found that the answer was 2 to hold the giraffe and 1 to fill the bathtub with power tools. And of course, you could go with D, which is the literal option, which is 1. And of course, since we're good CME people and we like to have an unsure option to be correct in our model, the answer is unsure. Surrealism is not my cup of fur. So what does this have to do with CME outcomes? I'm not quite sure, but I thought it was an interesting question. And well, actually, there is some things that it has to do with question design. I think one of the things here is all of these answers, we see overlapping of the answers. I think there's no one correct answer to this. So this illustrates one of the kind of common pitfalls we have with the distractors that we create for multiple choice questions that we use on our outcomes analyses. And so we'll move past this kind of farcical example and talk about some more of the meaty stuff here. If we can move on to the next slide, please. There's the references, by the way. Next slide. So really developing multiple choice questions in CME is a struggle between good and evil. And I think in addition to Johnny's secret weapon of this new study design, he's got a secret weapon that we're going to talk about in a little bit. And to give you a foreshadow of it, we're going to talk about using write-in data to actually help us develop better outcomes question distractors. But I think the reason why we like to use multiple choice questions are in the good column. They're quick and they're easy to answer versus essay questions. And in an ideal world, you give a long form essay question to 200 learners and sit down and analyze it. But the learners don't want to do that, and you certainly don't want to sit there and analyze it. So we get really rapid assessment, and it's a pretty good surrogate, if we do it right, for what we would get from a more a comprehensive survey of the learner's education level going into the activity and coming out of it, and then later on in practice. We can cover a broad swath of material with a number of questions. If you've got 10 questions across an activity, that you're going to get a pretty good sense of the learner's education level going in and what you managed to do in terms of improving their education as a result of an activity, which we'll refer to as validity, and we'll talk a little bit more about that. And you can also drill down on a learning objective and increase the reliability of the findings, and we'll talk more about reliability. The evil is kind of the downside of producing this type of an outcomes instrument. If you could advance the slide a little bit, Derek. Obviously, answer options are ambiguous sometimes, as we saw with the surrealist example. They can be guessable, particularly if you have bad distractors. In other words, by distractors, I just mean answer options that are incorrect. For ease of shorthand, I'm just going to call them distractors. And basically, if you are trying to fit questions to a higher level learning goal like competence or performance, it can be challenging to kind of get your team to understand the nuances of matching up learning objectives to content to outcomes. So I think plausible distractor creation is very difficult and is accompanied by symptoms such as wailing and gnashing of teeth, banging of head on the desk, and tearing out of hair, which is known as trichotillomania, if I got that pronunciation right. Next slide, please. So what is validity? If you advance that a bit, I think we all have a general sense of what's valid. If you go to a website and they ask you to type in your phone number and you type in an email address, it'll say invalid response, please try again. So I think we have a general layman's understanding of that. In education, it's a little more specific, and if we're talking about outcomes or multiple choice questions in general, if you advance the slide a bit, you can see that, and this is according to the Vanderbilt University Center for Teaching, their definition is of validity is the degree to which a test actually measures the learning outcomes it claims to measure. And this is pretty much more or less the definition of construct validity. So in terms of the different types of validity out there, for the validity theory nerds, this is usually considered to be the most important type of validity evidence. And we'll get into others in a little bit here. The next slide shows reliability. And this is the other thing we want our outcomes analyses to be. Really, a simple way to think of this is the reliability of an item or test is the degree to which it consistently measures a learning outcome. And we think that multiple choice questions are less susceptible to guessing, which makes them a little more reliable. And as I mentioned before, if you can drill down on a single learning objective with multiple questions, that's one way to increase the reliability of a test. Another good example of reliability is how well will two different groups of learners perform on a test, or will you get relatively similar results if you give the test in Cleveland and give the test in San Francisco, for example. Next slide. So if you're sitting there saying to yourself, well, how do I determine whether, or Johnny's sitting there and saying to himself, how does he determine whether his outcomes analysis is reliable or valid? There's one cheat sheet I can refer you to is Considine et al., and this is from 2005, and it was specific to nursing education, but they went through their best practices in terms of how they vet multiple choice questions that are being used for education analysis. And they preferred an expert panel review to establish content validity and face validity. And just very briefly, content validity would be, to what extent does our test items, I guess, legitimately from the intended content domain. So if you give a writer an assignment of doing multiple choice questions on lung cancer, and they come back with questions on metastases to the lung from a different type of cancer, and that might be an example of content validity where it needs some work. Whereas face validity is more or less a subjective measure that basically is can be referred to as eyeballing it, or I know what it is and when I see it. It's subjective, and if you have face validity, that's kind of nice. But I think, as I said before, construct validity, which is in the second bullet here, is really one of the best types of validity to shoot for when you're developing an outcomes analysis. And there's many different ways to do this, but I think distractor evaluation is in red here, and we're going to talk a little bit more about that. I won't get too much into reliability here since we mentioned it, but there's specific statistical tests that can be used to evaluate it. Next slide. Slide, please. So, of course, since infographics are very important these days, I decided to add one. And if you advance this slide a little bit, you'll see that this is illustrating baseline percent correct by use of tabby cats. And why do I do this? And really, I think this is a kind of a common source of anxiety in developing an outcomes analysis is, oh my gosh, what happens if we get too high of a baseline score on a pretest? How are we going to demonstrate that the education is effective? And I think this pink little toy here over to the left that represents a poorly designed multiple choice question. And basically this cat took the bait, jumped for it, and you can see, if you think of this, visualize this cat as a bar graph, that's a very high baseline score. But on the right, we see a cat that was adequately distracted, and we get a baseline score that's just right. So
I'm sorry, just to interrupt. This is the best slide of the deck, and I hope to start seeing it in outcomes reports moving forward. Thank you for putting it together.
I think so. I'm gonna have to like patent or copyright this or whatever you do with intellectual property. So it's very valuable. Okay, so next slide, please. So, and in terms of the anatomy of a multiple choice question, just so you can visualize it, if you advance it a little bit, you can see that the items in red are the distractors or the answer options that are incorrect. And this, I bring this up right now because it's another good example of kind of pitfalls and little nuances of outcomes item development that you can look at and improve your answers, improve the ability of your questions to actually measure baseline knowledge and learning uptake in the target audience. And if you look at answers C and E, do you notice that they're a little bit longer than the others? And the only reason this kind of caught my eye is because a lot of times the length of an answer option, we know, correlates with whether the answer is right or not. So if you're good at cheating on tests, you will look at C and E and say, boy, I bet one of those is correct. And in this case, this is an actual USMLE step 1 question or sample test question. If you would use that little cheating technique, you would increase your probability quite a bit of getting it right. Because if you just use that one cheating technique, you would have a 50-50 chance of just guessing this correctly. So if you go to the next slide, I'm not going to go through this because I just thought of this, and actually there's something I call the Gold Book. I'm sure it's not called that, but it's actually the National Board of Medical Examiners has written an extensive tome on how to construct an appropriate multiple choice question, and it's the last guide you will ever need to it. Those NBME, their website is very kind of tricky to get, and actually it's free, but it's tricky to get an actual copy of it. I'd be happy to email it to anybody who's out there and watching, but it's 100+ pages that is kind of boiled down into one slide like this. The common problems with distractors is they're not realistic, like we saw in the surrealist question, I guess. Unclear or ambiguous, or the ambiguity is that one where there's multiple answers that might be correct. Too wordy, like we saw in the vitamin slide. This is from the USMLE question, et cetera, et cetera. We're constantly dropping clues in grammar and form and length and language that make our questions easy to guess. And if you're still using all or none of the above options in 2017, you're probably in the wrong CME Palooza. So, if we go to the next slide, and this is kind of the secret weapon within the secret weapon for Johnny, which is using a special method of distractor development that maybe isn't used too much in CME, but in other domains of learning has been very effective and proven in this article from the JOSATL, I guess you would say, the Journal of Scholarship of Teaching and Learning, which contains a lot of words that are represented by this blah, blah, blah here. But the important point is that if you have an multiple choice question, having plausible distractors is really key to accurately measure knowledge or competence or whatever you're trying to prove with your educational analysis. So if you go to the next slide, what they did in this study is they actually took write-in responses and used them to generate plausible distractors. And how they did this is they created 2 different versions of the same neurohistology exam and gave it to medical students. So if you advance the slide a bit, and one more time, please. The took a quiz based on multiple choice questions, and the other students took a free response version of the same exam. And they found that and what they did was then they took the multiple choice exam. And they said, hey, some of these distractors are not working. Nobody is picking this option that's incredibly ludicrous and quite obviously wrong. They deleted those and cleverly crafted new distractors based on the incorrect answers that were in the write-in or free response fields for the other practice exam. So the thinking here is that if one medical student gets it wrong and they think this is a plausible explanation, if you present that exact same or similar answer to another medical student, you might successfully distract them. And why would you want to distract them? Because you want to basically be able to discriminate them as someone who needs the education and doesn't have it yet. So lo and behold, if you advance the slide a bit more, without getting into the statistical wherewithal of it, they were able to demonstrate that the new and improved multiple choice exam was in fact better, a better reflection of the actual knowledge level of the learner population, which in this case was the medical students. And I think for you, as a CME Palooza viewer, I mean, the question to you is this something that could be done in the CME field? If you advance it just a tiny little bit here to the next, one more time. The question is, I've been thinking about a lot, is how can we apply something like this in CME? You know, who is in our learner universe or in our faculty universe who we could work with to, you know, come up with more plausible distractors and come up with outcomes instruments that better help us discriminate between learners who need the education and learners that got the education later on in the analysis process. And with that in mind, we'll go to our final slide here, which is the take-home message. We see Johnny here is adequately distracted by a ViewMaster, and if you advance the slide to the bullet, the take-home point is that distractors matter. Again, I would say think about this whole concept of write-in responses, which really kind of captivated me a bit. And also, I would get a copy of this gold book, the NMBE Guide to Multiple Choice Question Item Writing. And I think it'll really up your game in terms of being able to create outcomes analyses like Johnny does that better measure the baseline and post-education level of learning of the target audience. And that's it.
And Andy, I'll tell you, we've got at least one person who has requested the MBME book, so I'll send you their email.
Okay.
I guess that's me. So thanks, Derek. Andy, thank you. And Jason, thank you for inviting me. And of course, Derek and Scott, thanks for putting this together. So I am responsible for the resolution data analysis, my favorite. So this is, we're going to get to the resolution of Johnny's story and get to the truth of what's really going on. Next slide. So far, Johnny has used his secret weapon, the pre-test, post-test, non-equivalent control group design with random assignment for his educational activity. Then he developed a survey that includes multiple choice questions with good distractors that validly and reliably measure how learners and controls performed. So now what does he do? He can conduct it. Well, no, he can't actually. You know, this is a trick question. What test should he conduct on his data? And it all depends on assumptions. Next slide. So we know the phrase about assumptions that generally aren't so good, but in statistics, we need assumptions. And basically, it just refers to the fact that different statistical tests require the data to be a certain way. So that's what's meant by assumptions. There are actually over 40 commonly used statistical procedures. Each one has their own set of assumptions, and it's really important that we understand which one to use at which time. So which one should Johnny use? He has the best chance of getting valid results if he uses the right procedure, which just mentioned. Some of the considerations for selecting a particular statistical test or sample size, dependent variable type, which I'll get into in a minute, the independent variable, underlying distribution, and others, which I won't get into, but next slide. So this is a table I created, and it generally goes over some of the common statistical tests you might use for two groups. So on the very left-hand side, you have your dependent variable, which is what you're measuring. And you have different types of dependent variables. You can have categorical variables, which are multiple choice or true false, ordinal data, which might be something like a Likert scale, rating scale, or you can have your interval or ratio data, which are also continuous data, and those are numeric data. And then on the right-hand side, you have your independent variable, and these are going to be basically your groups that you're looking at. So it could be pre-test, post-test. It can be participant versus controls. So we have independent groups, which refer usually to participants and controls, where you don't have any overlap between the subjects in the group. And those are going to have a particular set of appropriate tests depending on the dependent variable. And then similarly with the dependent groups, there's two definitions for dependent in this table, obviously. So on the very right-hand side, when I refer to dependent, I'm talking about the groups are dependent on one another. So if you have pre-test, post-test, you're ideally going to have the same participants in the pre as the post, and you're going to match those data based on an email or identification. So those are dependent groups, and those are some examples in the gray area for what tests are appropriate there. Next slide. So we're going to go through an example of Johnny's data, and we're going to assume that he wants to analyze data. We're going to look at one multiple choice knowledge question. The data will be pre-post, only from participants. So we're not quite getting at Jason's ideal model here, but it's just a subset of what we're looking at. So we're looking at two matched or paired groups, and they're going to be matched based on ID or email. And of course, Johnny has cleaned his data, so he's checked for outliers or test data. He's coded his multiple choice questions as correct or incorrect. Sometimes you do want to look at how people performed on particular distractors, but for this example, we're just gonna code it. If it's incorrect, it's incorrect. And we're gonna assume a sample size of 100 participants. Next slide. So which test should Johnny use? We have paired data and we have categorical data. And we don't have to go back to the previous slide, but if you were to go on that table, you would see that the McNemar's test would be most appropriate for this situation. Next slide. This is an example of what happens if Johnny chooses wrong, or if you choose the wrong test for categorical data. And these are actual data. So on the very left-hand side, you have data. The very first column is the learner. So you have 25 learners. The middle column is their pre-test data coded as correct or incorrect. So incorrect is a 0, correct is coded as a 1. And then in the right-hand column, you have your post-test data. And you'll notice it's all aligned per participant. And on the top, you have a McNemar's test, which is the appropriate test for paired data. And I circled some of I circled learner 2, just to kind of give you an idea of how the data are coded for McNemar's test. So you're going to look at that row 2 says he's got pre-test correct and post-test correct. And so that goes in the upper left-hand cell of that table. So it just kind of shows you the data are coded differently versus chi-square test. If you look down below, the data are not necessarily paired. You're just counting up how many correct responses do you have at the pre-test, how many correct responses do you have at the post-test, and same for incorrect. And if you'll notice, these are actual p-values. Using the correct test, we get a p-value of 0.15, and if you set your alpha at 0.05, which is typically done, then you'll conclude that any change from pre to post test was not statistically significant. Versus if you were to conduct a chi-square test, you would incorrectly conclude that there was a difference between pre and post test. So this is, I thought, a pretty good illustration of what can happen if you use the wrong test.
So just to clarify too, the incorrect test looks better, right?
Yes, it does.
Yeah.
And that's a problem because you don't want to, I'll get into it in a minute, but you don't want to think you did things right and then repeat your model in the future if you're really not affecting change. So you'd be wasting time and money if you repeated a program that really just wasn't successful. Okay, next slide. Okay, so there are two main types of error. I'm not going to get into too much detail in statistics. You have a type 1 error, which is basically the probability of a false positive. So in this case, you might assume clinicians actually learned something when they didn't. And if you make this type of error, you're missing an opportunity to make improvements in your programming. The other type of error is a type 2 error, and it's a false negative. So you might get a non-significant result, and you're going to assume, hey, it wasn't successful, clinicians didn't learn. But in fact, they did. So this is also a problem. So you want to avoid these, and one way of doing that is choosing the right test. Next slide. So everybody knows about p-values, and just to remind you, it's the probability of a type 1 error. So it's the probability of a false positive, and you want that to be as small as possible. The size of a p-value doesn't mean something was more or less significant. It just refers to the probability of a false positive, and that's something that people often get confused. So a couple problems with just looking at p-values is they don't tell you the size of an effect, and they're also dependent on sample size. So the graphs here are, again, actual data, actual p-values, and you'll notice with a smaller sample size, the graph on the left, each group had a sample of 36, and you get a non-significant p-value of 0.09. But if you go to look at the graph on the right, much larger sample size, and you do get significance. So that's what is meant by p-value being dependent on sample size. If you have a large enough sample size, if there's any bit of difference between groups, large enough sample size, you will get significant p-value, but it might not necessarily mean as much for you as an educator. Next slide. So this is where we come to effect size, and this is also important to report in outcomes. It's a standardized measure of the magnitude of a difference between groups. These are some examples of effect size. Everybody's heard of Cohen's d, and that's usually used for continuous data. Odds ratio is another example. Kramer's v. Correlation coefficient is an effect size. Glasses delta and Hedges G are also examples of effect sizes. So different, you'll use hopefully the appropriate one depending on what data you're looking at. And effect sizes are not intended to replace p-values, but to complement them. So if you get a significant p-value, you can also report how big was the effect size. Oh, and one other thing. A lot of times, Cohen, I believe, was the one who had a rule of thumb where an effect size of 0.2 is considered small, 0.5 is considered moderate, 0.8 is considered large. He was actually hesitant to come out and say that it's a lot's going to depend on the industry, and I think that's something maybe we need to figure out in CME, and I will credit Derek Dietz for bringing this up in my presentation at the Alliance QAS meeting, that we kind of need some standard in CME industry of what is a meaningful effect size. We have, at CME Outfitters, we have been reporting sort of these rules of thumb in our outcomes reports, and they do seem to correspond to the kinds of improvements we've been observing, but it's probably a good idea if we can all just kind of get together and figure this out for our industry, what's meaningful in terms of effect size. Next slide. Okay, so Johnny cleaned his data, conducted his McNemar's test. He found 43% of participants in the pre-survey got the answer correct, and it went up to 89% for the post-test. Significant McNemar's test, p-value was less than 0.001, and he also calculated an odds ratio of 3.6. So that's his effect size, and basically that's telling you the odds of a correct response for the post-test is 3.6 times that for a pre-test. And this is another one of those, yeah, there's guidelines for telling you, well, is that small, medium, large? Some people will say that's sort of in the moderate range, 3.6, but again, it's kind of subjective. Next slide. Oh, I think I do have time. Okay, so we're not quite done because, of course, I had to talk about one of my favorite things. So Johnny really wants to know what contributed to his learners' improved knowledge. So he can be sure to keep doing whatever he's doing. So how's he going to do that? Next slide. predictive modeling, of course. So generally, predictive modeling means you're going to predict values of a response variable based on one or more predictor variables. So Johnny thinks that specialty, academic degree, years in practice, and or maybe confidence influenced post-test knowledge. So for this example, we're just looking at sort of a snapshot in time. We're not really comparing pre to post, I don't think. Okay, so there are different types of predictive modeling. A lot of people probably heard of regression. That's the most common form of predictive modeling. There's linear regression, which is used for continuous predictor and response variables. Logistic regression has a categorical response variable and any kind of predictor variable. CHAID, which stands for chi-square automatic interaction detection. It's a mouthful, and it's what we use at CME Outfitters. And what we like about it is it can be used for continuous or categorical variables. And ANOVA, analysis of variance, you've probably heard of that. That's actually, in a sense, predictive modeling because you have a continuous response variable and categorical predictors. So it's sort of, ANOVA and linear regression are sort of two sides of the same coin. And of course, I was allowed to plug my upcoming workshop at the Alliance meeting in January. So come to that if you want more. But I have one more slide on predictive modeling I'll just go through quickly. So this is general steps in conducting a predictive modeling analysis. First, you're going to ask your research question. So Johnny wants to know what variables predict response on a knowledge question. And I am not the actor like Jason is, so I'm not changing my voice for this one. Determine the time point. So do you want to look at your pre-test scores, your post-test scores, or your difference scores? Johnny chooses a different score. He does. Okay, that was what I thought on the previous slide. So Johnny's going to look at, for each participant, he's going to calculate the difference score between pre and post. He's going to select his predictor and response variables. This is somewhat subjective. There aren't really any rules of thumb, especially in CME, in terms of what predictor variables are important to look at. Then he's going to select his model. Again, this will depend on the type of data that you're looking at. He decides that logistic regression is the most appropriate for what he's doing. He's going to conduct his analysis, and he found that academic degree was actually a significant predictor of post-test knowledge. Then he looks at subgroups and finds that NPs and PAs improved the most. So this kind of gives him an idea of maybe what groups to target for education in the future. Okay. So then he's going to interpret his results and then go to just help develop his future activities based on his results. I think at this point, do I bring it back to Jason? Does that work?
Sure.
Okay.
Yeah, if you could, thank you, Jamie. If you could just jump ahead one more slide. We're going to put a final little bow on this. Just to kind of summarize what we covered. It's not the data, it's the design. I will take Andy's well-designed survey in a well-executed model, study design, over chart review any day. It's more robust, and the stuff that comes out on the back end is going to be more valuable. Study design is a very, very important first step. Moving on to Andy's part, the second part of the discussion, proper measurement ensures your data reflects your intention. Just because you want to measure something, as Andy went through, doesn't mean you're going to actually do it. Now there's a whole other thing, a whole other slew of things you need to consider. He's given you some shortcuts. National Board of Medical Examiners, they offer excellent resources. Most of them are free. I highly, highly recommend them. Why go through the trouble of designing a great study only to then drop the ball in the measurement section? So, go back and look at those resources. Some excellent recommendations there. And lastly, with Jamie and analysis, she talked about whether an effect is present, to what degree, looking at predictive modeling and trying to find out what influencers are. I'm going to summarize it even more and just say that the analysis can either make all of your hard work in the previous steps really shine or not. As she went through, if you're using the wrong test, if you're making the wrong assumptions, if you're making the wrong interpretations, you could really go all over the map. What we want at the end of the day is as pure of a line as possible between what we do and what we hope to influence. And, she said it was a shameless plug. I have to say, I sat through one of her predictive modeling sessions before. She's an outstanding teacher. I highly recommend you go to the Alliance one. I didn't give her enough time today to go through it the way I know she would. She's taught me plenty, and I think she can take anybody from a beginner to more advanced to give them some great tips. So I feel very happy and lucky to be able to talk today with Andy and Jamie. Derek, thanks for the opportunity. If there's any questions, we'll use the last 5 minutes to answer them. And thank everybody very much.
Yes, we had 2 questions. One is quite long, and it's going to take us too long to answer, so I'm not going to do that one. The second one's very short. Someone wants to know what your favorite John Cusack movie is and why.
Oh, Ben Collins, thank you. So I need a second to think about that, but I know Andy's much quicker on the pop tip than I am. Andy,
I don't know if it's my favorite one, but I was just thinking the other day how much I like his car in Grosse Pointe Blank. So that might be my favorite.
Good choice.
What was it?
I think it was like a Lincoln Continental or something. I don't know. It looked really tough.
Good Hitman car. Okay.
Ooh, does 16 Candles count?
Sure.
Was he in it?
I mean, close
He
enough.
was one of the nerds. He was one of the two.
He
nerds.
was one of the nerds.
Yeah.
That's right. Obscure. I'm okay. Like that. I'm going to go with One Crazy Summer.
Very good. I'm going to go with High Fidelity. So there we go. And I'm going to close this out real quick because Scott is probably chomping at the bit because he needs to bring up the next session. So let me do my closing. Oh, contact information, etc. Please take our survey. We just talked all about all the outcomes, so we need some outcomes too. So take our survey. There's a link for it on the live page. And lastly, just remember we have one more session to go. Building a better grant request. I mean, what could be better than that? It'll start up in 3 minutes. You'll have to refresh your screen and then go to it. For the outcomes panel, thanks so much. That was really great. I appreciate it. Good information. Everyone else, I will talk to you all later on. And we're going to end our broadcast.